Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Christopher McCrum from Dallas, Texas. Dr. McCrum is an assistant professor in the Department of Orthopedic Surgery at the UT Southwestern Medical Center. He obtained his bachelor's degree in movement science from the University of Michigan, and then he earned his medical degree at the Case Western Reserve University School of Medicine. He completed a residency in orthopedic surgery at Los Angeles County Hospital and Keck Medical Center at the University of Southern California. Then received advanced training in sports medicine through a fellowship at the University of Pittsburgh Medical Center. His research interests include joint preservation and cartilage replacement, stem cells, shoulder and knee surgery, and return to play outcomes in elite athletes. He's also a reviewer for a number of sports medicine publications, and he serves on the editorial board for the Arthroscopy. If you have noticed, Dr. McCrum has lectured with us in the past, which was a fantastic lecture. And today, it's my great honor to bring back Dr. Christopher McCrum for this wonderful live program. Over to you, Chris.
Wonderful. Thank you very much for having me. Today, I'll go through quadriceps tendon autograft for knee ligament reconstruction with particular focus for using the quadriceps for an ACL reconstruction graft. Here are my disclosures. They don't influence anything in this particular talk. So to start off, the most important thing when considering any procedure is the relevant surgical anatomy. For the quadriceps autograft, that anatomy is the distal aspects of the quadriceps tendon. As the name would suggest, it's the confluence of 4 different tendons, and there is some variability from individual to individual with regard to the morphology of this tendon, but the muscles that contribute to this are the vastus lateralis, vastus medialis, vastus intermedius, and rectus femoris. And the shape of these insertions are the medialis and lateralis come in from medial and lateral particularly, and the rectus femoris is superficial while the vastus intermedius is deep. And the advantage of using the quadriceps tendon or considering the quadriceps tendon as a graft when we're comparing to the other tendons that would be considered a gold standard autograft for an ACL, such as the patellar tendon and the hamstring tendon, focus more on its size and composition. The quadriceps tendon, if we take a central quadriceps tendon graft, is nearly twice as thick as the patellar tendon. And if you're considering taking a bone block, there's about 7 to 10 millimeters of bone on that proximal patella from anterior to posterior that can be considered for the bone harvest. On average, there's about 6 centimeters of common tendon that extends from the superior pole of the patella. And that tendon distance can be actually increased for the harvest when you consider that there's another about 2 centimeters on average that have a split rectus femoris and vastus intermedius. And there's a dual purpose of this if you consider, or your technique is to do a double bundle graft, either for the PCL reconstruction or for ACL reconstruction. This is a natural split in the graft that you can use to your advantage for that purpose. The average width of the quadriceps tendon distally itself is nearly 3 centimeters. So it can easily allow for the harvest of a graft 9 to 10 millimeters in width. And the average thickness of the graft is generally about 7 millimeters thick, and it can range up to, it can be up to about 8 millimeters at the largest. That is in comparison to the patellar tendon. While you can get a nice 10 millimeter size bone block from that type of a graft, the tendon itself is only about 3.7 millimeters thick along the course of the patellar tendon. So the layers themselves, again, deep is the vastus intermedius, medial is the vastus medialis, and vastus lateralis for the middle layer of the tissue, and the superficial layer is rectus femoris. And again, they confluence distally. And while there is variability between individuals, it's always a good choice for grafts. When you're harvesting it, it could be bilaminar, trilaminar, or even quadrilaminar with regard to the fiber orientation, and that's important when you're potentially harvesting that minimally invasively to be aware of where exactly you are in the tendon. As to the biomechanics, again, it performs very admirably, both compared to the native ACL as well as what would also be considered gold standard grafts of the patellar tendon, autograft, and the hamstring tendon. When we look at biomechanical strength testing at time 0, There's almost a 2 times larger cross-sectional area with compared to the patellar tendon. And you can predict how large of a graft you're going to get for the quadriceps tendon, both by ultrasound or MRI. And there's been studies out of Pittsburgh that have evaluated this and shown that these are both reliable methods at predicting what your ultimate graft size is going to be. Ultrasound might be a little bit better actually for this purpose, particularly since sometimes when you get an MRI, you don't see the entirety of the quadriceps tendon, depending on how that study is protocoled. When you look at the ultimate load to failure and stiffness, it also compares favorably to these grafts as well as the native ACL. The stiffness, it's significantly stiffer than the patellar tendon autograft, nearly twice as stiff, in fact. The kind of most stiff graft and the highest ultimate loader to failure is this quadrupled hamstring tendon graft, which is about double what the quadriceps tendon is. But if you look at this table that was found in a recent article in the Yellow Journal of the Academy of Orthopaedic Surgeons, you'll see that the quadriceps tendon with regard to the ultimate load to failure is very, very similar to the native ACL itself, and actually has a little bit more native stiffness, whereas that quadrupled hamstring tendon has super physiologic load to failure and stiffness. If you look to the histologic composition of the quadriceps tendon graft, it actually has greater collagen density compared to the patellar tendon, and that might be what has resulted or what leads to this increased in strength and stiffness compared to that type of a graft, in addition to the size itself. So recently, there's been a lot more interest, both research-wise as well as clinically, in using the quadriceps tendon as an autograft, both for ACL in particular, but also PCL and other different grafts. In 2011, only 9 papers were published on ACL autograft with quadriceps tendon, and that was up to 63 in 2020, and there's already been 20 that have published this year already. It's important to remember, though, that this isn't a new graft. There's actually a quite good follow-up in the data. It was first introduced in the 1970s and early 80s, and it was kind of popularized throughout the 90s and early 2000s by Dr. Fulkerson. It's gotten more popular due to new, different harvesting techniques, such that we can more reliably get a good graft, and we can do this also minimally invasively. Such that we can do even potentially a 1 centimeter or 2 incision in order to get this harvested in a safe fashion. So if you look at the actual utilization, again, the utilization is becoming more popular, but it's by no means becoming the most common graft quite yet. Hamstring tendon remains most popular. Patellar tendon is also more popular than the quadriceps tendon still, but we're up to about 10% of ACL grafts in the primary population being primary quadriceps tendon, which is significantly greater than the very, very tiny amount even 5 or 10 years ago that we saw, as you can see in this study. It's particularly useful in the context of revision. In a recent study, up to half of grafts used in revision ACL were quadriceps tendon, although that might be related to the sample size and the institutions where this study came out of. If you look at quadriceps tendon as far as how it does clinically, if you're considering adding it to your practice, I think always the best place to start would be the patient-reported outcomes. And there's been actually multiple randomized studies that have been very well done that have looked at this exact topic, both comparing it to patellar tendon and hamstring tendon. And if you look at patient-reported outcomes like the subjective IKDC and KAOS or KU scores, there's no significant difference between the quadriceps tendon and the patellar tendon. There's no significant difference in these grafts either when you look at the objective IKDC, which isn't a PRO, but is also very useful and clinically relevant information. When you compare it to the hamstring tendon, there's multiple studies that have shown that the functional outcomes are similar, and there's even been a couple of publications that have suggested that quadriceps tendon may perform slightly better with regard to functional outcomes compared to hamstring tendon. When you look at graft failure rates, I think that's another thing that's critical to look at when you're considering adding a new graft to your armamentarium. There's no significant difference between the quadriceps tendon and the patellar tendon, which is kind of considered the gold standard with regard to re-tear rate. If you look at a large meta-analysis that was historically done with patellar tendon and hamstring tendon, we can see in that population, we see about a 2.8% re-rupture rate. And that's probably about what we would see for a well-done ACL reconstruction in a primary setting. When you compare directly these two graphs, there's been about 6 studies done in a randomized fashion. And the re-tear rate for the quadriceps tendon is very similar to what you would see published in the literature. These authors, if you look at everything together, would have about a 3.5 re-tear rate in patellar tendon, which is slightly higher than what's been published, but certainly within the realm of expectation. When we compare hamstring tendon to quad tendon, this is where we may see a little bit of a difference, with the quadriceps tendon potentially having a slightly lower failure rate compared to the hamstring tendon. But if you just look at the general gestalt of the data and you kind of combine this all together, I wouldn't say there's a significant difference between any of these graphs with regard to failure rates. So there's nothing that would necessarily scare you away from adding a quadriceps tendon autograft for a patient. With regard to graft laxity, this is another place where quadriceps tendon may perform a little bit better than hamstring tendon. Although if you look at the meta-analysis of all these studies, we don't see a significant difference between any of these different grafts. Donor site morbidity is one of the big advantages, particularly in my practice when I'm considering using a patellar tendon autograft versus a quadriceps tendon. Certainly patients who have a patellar tendon autograft have a high reported incidence of anterior knee pain and or kneeling pain onto that graft site. And while there are things that you can do to mitigate this, this complication, like bone grafting your harvest site, particularly on the patella, the quadriceps tendon, we don't see that, particularly if you harvest an all soft tissue graft. So if you've got a patient that you're particularly concerned of this anterior kneeling pain, but you think they're a better candidate for an extensor mechanism graft than a hamstring graft, I think quadriceps tendon is a really good choice. And things like in the United States, baseball players who play catcher would be an important population to think about. Certainly, many people with their daily activities of living or some of their faith practices may require a lot of living. Carpenters may require a lot of kneeling. Those are patients that you may want to stay away from the patellar tendon. I think quadriceps tendon is really found a home when trying to minimize your donor site morbidity. So one of the red flags that's come up in the early data collection came out of some of these Danish registry studies, particularly a study that came out that showed a significantly higher failure rate for the quadriceps tendon versus both hamstring and patellar tendon. And this has not necessarily been replicated in other studies. And I think more follow-up is going to be needed to see why we've seen this relationship, as they publish as high as a 5% re-tear rate or failure rate in their quadriceps tendon population. A recent study that was published in 2020 in September suggested that this may have been related to surgeon volume or medical center volumes, where they saw a significantly lower revision or failure rate for the quadriceps tendon in the high volume clinics compared to the low volume clinics. So there may be a learning curve that's associated with this, but certainly more studies are going to be required in order to say that with any sort of certainty. So I'll move on to technique, which is what we'll try to focus on this talk, as well as how to try to stay out of trouble and reliably get a good graft. So Astro approach, you want to place the patient supine, and you can either flex the knee to 90 degrees or place the thigh in a well holder and put the bed of the table down to allow the knee to flex to 90 degrees. This will put the quadriceps tendon under tension and allow you to get a good amount of resistance and reliability in harvesting the graft. A good way to start learning how to do this graft is open in order to completely appreciate the anatomy, but this can certainly be done very safely through a minimally invasive endoscopic aided approach as well. If you were to do this open, you require about a 4 to 5 centimeter incision that you center over the proximal patellar pole. Endoscopically, you can minimize this with a 1 to 2 centimeter incision over this area. Now, this can be done either vertically or horizontally. My preference is to do it vertically in the case that I need to extend it. But cosmetically, if you go on Langer's line, a horizontal incision could be actually quite cosmetically pleasing. One thing to make patients aware of if you're going to make a vertical incision in this area, that many patients do hypertrophy the scar on this area of the knee, as there is quite a bit of motion of the skin in this area. So this is something to make patients aware of preoperatively, so they aren't surprised afterwards. Skin anatomy or superficial anatomy. I like to mark the vastus medialis, which is quite easily noted coming in distally, where it contributes, as this is going to be your medial border where you're going to harvest that central quadriceps tendon. Particularly if you're going to do endoscopic, it's very helpful to excise the subcutaneous fat, which will help with visualization. You can see in the picture to the right, you have this subcutaneous fat that's getting in the way of your visualization that I then excised. And you can see once that fat has been excised, you get a nice visualization of the vastus medialis there on the left, as well as the more proximal extent of the quadriceps tendon. The next step would be to take a Cobb elevator, and I like to use a laparotomy sponge to help dissect that subcutaneous tissue off of the quadriceps tendon and peritoneum in order to get good visualization. This can, again, be done endoscopically, where you just put the sponge in the 1 centimeter incision and just gently press forward with that Cobb elevator to separate these layers. Then you can put a retractor, either something like a Army-Navy retractor, a Richardson retractor, to elevate up that subcutaneous tissue, and you could visualize endoscopically to make sure that you've appropriately elevated the subcutaneous tissues. One place that you can get into trouble is if you don't appropriately elevate those tissues. That could block your harvesting and could lead to truncating the graft short. So I find it to be very helpful to visualize this endoscopically to ensure that I do a good job at elevating those tissues. When you're harvesting the graft, you want to get about 70 centimeters of graft length. And you can take into consideration, if you're taking a bone block, you can get actually even a longer graft, up to 90 millimeters or so, which is useful if you want to do something like a posterior cruciate ligament reconstruction. For an ACL, I aim for about 70 millimeters in graft length, depending on the patient's size. This allows for about 50 millimeters in the femoral tunnel and 20 to 30 millimeters in the tibial tunnel. You want to beware distally, as you can see here. You don't want to get too close to the rectus femoris myotendinous junction, as this can lead to a Popeye deformity of that muscle. Again, you can endoscopically visualize where this 70 millimeter point is going to be. The technique I like to use is I'll put the endoscope into the incision. I'll advance it 70 millimeters, or I'll advance up to the rectus femoris, and I'll mark one of those two structures, or perhaps both, superficially on the skin, for two reasons. Number one, so I can have an idea of how long of a graft I'm going to need when I'm harvesting this endoscopically. But also to have an idea of which direction that I want to push in order to avoid pushing when I'm harvesting away from where I'm ultimately going to want my graft or harvest my cut. The next step will be to take either a double blade, or you can just harvest parallel cuts. Generally, I'll get either a 9 or a 10 millimeter width of a graft, and the graft should be 6 to 7 millimeters deep. Again, remember, this graft on average is somewhere between 6 and 7 millimeters. And my preference is to take a partial thickness graft, which we'll talk about in a second. So one thing that is reported to be a complication of this graft is hematoma. There's penetrating vessels, both medially and laterally. More distally, those vessels tend to be medial, and they're going to come just into that vastus medialis muscle belly. And these are things that I suggest cauterizing, so that when you harvest, you don't accidentally tear these veins. And it's never a fun surprise when you let the tourniquet down to have a large amount of bleeding that you have to then go find endoscopically. So you can certainly evaluate these veins endoscopically and cauterize them as you do the approach. I think it's also important at the conclusion of the case to let the tourniquet down before closure to make sure you haven't missed any injured vessels that may lead to a hematoma. More proximally, and probably more consequentially, you have the lateral femoral circumflex artery branches that anastomose onto the lateral geniculate arteries. And this is between the vastus femoris and the rectus femoris. If you're too proximal with your harvest or too lateral with your harvest, you can get into this. And this is a much more consequential problem, because you can actually devascularize the quadriceps muscle, and this is much more likely to lead to a big hematoma if this were to be done and you didn't notice this at the time of surgery. So as far as graft harvest technique, again, you can either harvest a bone block or soft tissue. With a soft tissue harvest technique, you continue those parallel cuts all the way up to and onto the proximal patella, and you elevate this subperiosteally. Again, I like to harvest a partial thickness graft. There isn't a great deal of data out there on partial versus full thickness quadriceps harvests with regard to postoperative outcomes or rehab. Even with a partial thickness graft, you can get a great thick 10 millimeter or even bigger quadriceps tendon graft. So there's no need size-wise to necessarily harvest a full thickness graft, and there's certainly enough width that you don't need to increase your width to get a good diameter graft. The reason that I like to take partial thickness is anecdotally, I've noticed some of my full thickness grafts have a little bit more trouble getting their quadriceps strength back postoperatively with rehab. And in the operating room, another advantage of doing the partial thickness graft is you're less likely to make a traumatic arthrotomy, which is something that's going to have to be repaired later. And if you don't get a watertight repair, you lose your arthroscopic fluid pressure, as the fluid can easily escape out of this traumatic arthrotomy. So what I end up doing is I'll elevate subperiosteally for a couple of centimeters, as you can see in this top picture, and then I'll tag this with a locked Krakow fashion stitch to control the graft, which you can later use. For me, this will be the tibial side of my graft. You could then turn the blade horizontal once you've located the appropriate layer, about 6 to 7 millimeters deep, to then start harvesting this graft. And you can combine this with blunt dissection, as once you've gotten a couple centimeters onto the graft, finger dissection is usually sufficient to be able to separate these layers out. If you want to harvest a bone block, again, this has the advantage of bone-to-bone healing, but also it can give you a little bit longer graft. For me, I'll use the bone block, particularly if I'm going to use this as a PCL reconstruction graft. Also, if you have a patient with a short quadriceps tendon, as measured less than 60 millimeters on your MRI scan, or on the first step of this procedure when you're evaluating this endoscopically, I would strongly consider using a bone block. Particularly, there's a recent article in KSSTA in 2020 out of Japan, where they showed that patients with graft length or quadriceps tendon length shorter than 60 did not have sufficient autograft length with soft tissue alone. The other thing to remember when you're planning out, again, MRI doesn't always evaluate proximally, so always check this clinically before you commit to one graft harvest. For me, I take a 20 millimeter bone length and I take a triangular cut, and I generally go about 7 millimeters deep, and you aim trapezoidally. You can't aim distally, because this area of the quadriceps, unlike distally, if you're harvesting a patellar tendon graft, does have cartilage. So you will make a traumatic injury to the cartilage if you violate that subchondral bone distally. The other problem with taking too thick of a graft is patella fracture. This has been reported at up to 8.8% with quadriceps autograft taking a bone block, but also as low as 0.2% to 1.8% with patellar tendon. And there's a couple different reasons for this. There was a recent study that it actually came out of the same group in Pittsburgh that reported the 8.8% rate. They evaluated some of these fractures, and they found that the harvest depth is a significant contributing factor, particularly since increased bending stress is seen at up to 42% of the patellar tendon width. So their suggestion was to limit your harvest depth to no more than about 30% of the patellar depth. Additionally, you want to make sure that you err more medial than lateral, but you certainly want to get central. If you're too lateral, again, this is going to increase the bending stress of that area where you take the graft. Finally, you don't want to take more than 50% of the patellar length. So if you have a patient with variable anatomy and a very short patella, you might want to take a shorter patellar bone block as well, or potentially consider an all soft tissue graft. Now, that being said, the metrics you want to look at when you're harvesting, you want to look at that quadriceps tendon, and you want to make sure that you're in line with the fibers, and you want to make sure that you're very central on that patella when you take the bone block. And finally, again, I hate to emphasize this again, but you want to take a trapezoidal, not a rectangular bone block here, as you will get both a risk of fracture as well as you can get intra-articular and take cartilage. As to the traumatic arthrotomy, if you do accidentally take a full thickness graft, or you intend to take a full thickness graft and you get into the suprapatellar pouch, it's not a big deal. You just need to repair this, and this can be done either open, where you can use like an O braided absorbable suture, and I use figure-of-8 Vicryl sutures. If you do endoscopic, this may be technically challenging to do with an open suture needle, but one technique you can use is an arthroscopic suture passer, such as what you'd use for a rotator cuff repair, in order to pass the sutures, and an arthroscopic knot pusher in order to pass the knots down. This is a very easy, technically feasible way to close this without necessarily having to extend your incision. Again, you'll notice right away if you get a good watertight closure is when you put the arthroscope in, fluid will extravasate out this wound. Now, that being said, once you flex the knee up to about 90 degrees to prepare the notch, sometimes you don't get as much fluid pressure in the suprapatellar pouch, so it might not be as big of a problem. So in order to complete the graft harvest, you can do this either open or endoscopically. To do it endoscopically, you generally need to use one of these proprietary suture harvesting devices. To do it open, it's very simple. You can just truncate the graft either with a blade or a Mayo scissor. You can potentially do this minimally invasively as well, but I would suggest if you were to do that, to actually do this under direct visualization with the endoscope in the harvest site in order to ensure that you don't accidentally truncate the graft low or iatrogenically rupture the quadriceps tendon. And that's something that's helpful to do with an assistant in the OR to help hold the camera. These devices, however, make this harvest much easier and much more technically feasible. There's a couple of proprietary devices where you basically just need to pass that prepared distal end of the graft through and gently push forward, and then you truncate the graft. All of these devices do have measuring lines on it, so you can see exactly how long of a graft you've harvested. Potentially, you can use a hamstring tendon harvester, but you need to make sure you have a large enough diameter harvester, as these generally only go up to about 8 or 9 millimeters in diameter. Technical considerations, you want to make sure that you are in line with your previous incisions into the quadriceps tendon, as this is a very easy way to accidentally truncate your graft short. So you want to make sure that, again, you're pushing towards that insertion, and you want to aim both towards that mark you put on the skin earlier in the case where you were aiming at the rectus insertion, but also at the AIIS, or the anterior inferior iliac spine, where that rectus is inserting more proximally, is another important landmark that you could be aiming at. It should be fairly easy to push all of those devices forward. So if you're coming up against extra tendon, it never hurts to put the endoscope back in and make sure there's not a fibrotic band, or there might be some subcutaneous tissue that's blocking you. As to other factors that may lead you to harvesting a short or incomplete graft, you need to, again, remember the anatomy of the quadriceps tendon. So remember from earlier in this presentation, about 6 centimeters of that distal quadriceps graft tends to be confluence into one tendon, whereas more proximally, you have the vastus intermedius deep and the rectus femoris superficial. So if you're harvesting a partial thickness graft, sometimes when you get to about 6 centimeters proximal, there's a little bit more resistance, and that may be because you're getting into the the vastus intermedius, and you need to be very careful not to accidentally truncate that part of the graft short. So you want to be cognizant of where you are in the graft harvest. Now, while this might be technically challenging and you need to be paying attention to that, one way to avoid it is to make sure that your double blade and your cuts initially do go through that vastus intermedius proximally, as that'll block the tendon harvester from easily passing over that tendon. And what it'll do is it'll just skive into that vastus intermedius tendon, and you'll have a much smaller graft on that proximal area if you truncate it. Now, if you do this well, it also has the advantage because you're going to get a nice double limb graft. So if your technique is to do a double bundle graft, this is a nice way to get a double bundle, because you'll have a natural tissue plane, as these tendons tend to be separated by a small area of fatty tissue that you can then create your 2 different tunnels, or graft for your 2 different tunnels. Fixation options. So quadriceps tendon allows you to use really any fixation option that you want. Now, if you're taking a 65 to 70 millimeter graft, generally that requires suspensory fixation on at least one side of your ACL reconstruction. There's no study out there that shows that any particular graft option is superior over another with regard to quadriceps tendon. My personal preference is generally suspensory on the femoral side of the graft and either interference or suspensory fixation on the tibial side of the graft. As to avoiding construct loosening, so particularly with some of these adjustable cortical fixation devices, there's been some reported loosening or increased laxity on biomechanical studies. And some people have noticed this clinically as well. What I've found, one trick to avoid this is to simply tie a knot over that adjustable device, and that'll prevent any sort of sliding of the device after surgery. So this can be done on the femur through that little poke hole that the beath pin is pulled through. You just get an arthroscopic suture pushing device. The technical challenge with this is to make sure that you don't set the grafts on the iliotibial band. So I push this suture pushing device down a couple of times to make sure I can easily get it through the iliotibial band and sit directly onto the cortical button. I visualize the cortical button flip arthroscopically, but you can do that via fluoroscopy as well. But I would suggest visualizing either via fluoroscopy or through the bone terminal to make sure your button flips, as there's been a couple of publications lately that shows a high rate of the button either not completely flipping or flipping over the iliotibial band in the soft tissue, which may be another reason that you can get some construct loosening postoperatively. If you use suspensory fixation on the tibial side, again, you can either tie a knot over this area. I would be cautious if you do that, particularly on thinner individuals, as these non-absorbable sutures can be fairly irritating on the skin. So you can either tie a knot and use a knotless anchor, or simply use a knotless anchor to just knock that device down. So if you compare quadriceps with bone versus all soft tissue, there was a recent systematic review, again, out of multiple institutions. 24 total studies were included where they had either bone and or soft tissue quadriceps autografts. They did find a little bit more rotatory instability with bone tendon autograft, although I think this might be limited by sample size, as the reported rate was 0 on one side of the study and 0 to 39% on the other side. So there may be an issue with heterogeneity, and I think further study is likely, at least my opinion on this is further study will likely show there's not a big difference, particularly since we all know that there is an advantage with the bone-to-bone healing with these grafts when we think about patellar tendon autograft. The big difference between these grafts, and I think this is something that's salient, is the difference in complication profile. So with the quadriceps tendon with bone block, there's a wider complication profile versus the soft tissue. So quadriceps tendon with bone block, you also saw Patella fracture, which is a little bit more anterior knee pain, but that wasn't statistically significant in this study. But that's a complication that we don't see necessarily to that degree in soft tissue harvest, such as hamstring or all soft tissue quad. And they importantly found no difference in re-tear rate. With regard to clinical outcome scores, there is no significant difference. Lastly, I'll touch on rehab. A couple of recent meta-analysis suggest that patients having extensor mechanism harvest, and that includes patellar tendon and quadriceps tendon, may struggle to get their extension strength back postoperatively, particularly when compared to hamstring autograft. And that's early in rehabs. But once we get further out to 5 to 8 months, or even up to 8 months to a year, we stop seeing necessarily that relationship. So I think certainly earlier on, and my experience confirms this, early on, patients do struggle to get their extensor mechanism strength back. And I've noticed even anecdotally, compared to my patellar tendons, they might be a little bit slower. But by the time patients get to 8 to 12 months, they're pretty similar to the average ACL patients. Now, that being said, and I think this is across all grafts, across all of the literature, that limb symmetry index doesn't always get beyond 90% until up to 2 years after surgery. And that's with quadriceps tendon, but we also see this with other grafts, including the hamstring grafts. I think the most important thing to look at, though, and I think this is something that comes into play when we start looking at these studies that report higher failure rates of hamstring tendons, particularly in adolescents, females. Quadriceps tendon have a higher hamstring to quad ratio compared to these hamstring grafts. And this may be protective against re-rupture. Now, you think we talk about the hamstring being a secondary stabilizer to anterior translation at the knee. So when we're thinking about trying to protect our grafts, We know that hamstring autograft does decrease our hamstring strength, and that's something that can be permanent. It may be advantageous if you're looking for a soft tissue graft to think more seriously about the quadriceps tendon, particularly in these adolescent females, as these patients are more susceptible to having being more quad dominant, which may be a risk factor for their re-tear. So I think in my practice, actually, these adolescent females are excellent candidates for quad autograft for this particular reason. So in conclusion, I think quadriceps tendon autograft compares very favorably to these gold standard grafts, whether your gold standard is a patellar autograft or a hamstring autograft. The data on the literature says that laxity, failure rate, and complications are all similar between these grafts, as are the clinical and patient-reported outcomes. I think my opinion on where these grafts are particularly useful, so revision, oftentimes the patients have already had their hamstrings or their patellar tendon used in the graft, so you don't necessarily want to go back to that well again. And I think quadriceps is significantly better than an allograft in a revision situation. I think quadriceps tendon is an appropriate graft for athletes. Certainly in the US, generally our athletes are getting patellar tendon autografts, and I think a lot abroad are getting hamstring as well. But I think quadriceps has performed to the degree that I think it's a very excellent option for athletes, particularly athletes that may require kneeling or the anterior knee pain may be a concern. If patellar tendon is your go-to graft and you've got a skeletally immature patient, I think quadriceps tendon is an excellent choice. Again, for me, these skeletally immature females, where historically a lot of surgeons would err to the hamstring autograft. I think the quadriceps tendon is an excellent graft for those patients as well. So thank you very much for having me and your time, and I welcome any questions.
Thank you, Chris, for yet another fantastic lecture from your side. A few questions. One is regarding the graft options. You have mentioned a lot of these. If a soccer player, for example, a forward, comes to you, what is your preferred option?
Yeah, so I mean, I think for me, it's quadriceps tendon, and it's for a lot of the things that I've highlighted. I think the morbidity profile for that graft does compare favorably. Now, I think the two grafts that I would consider are the patellar tendon and the quadriceps tendon, but just this anterior knee pain issue, I think that's what started to lead me more to quadriceps tendon. Now, I think just in general, for me, I'm very big into kind of shared decision making, particularly with high level athletes. So I think their thoughts are critical in evaluating that. But I mean, I think quadriceps tendon, absolutely, even in elite athletes, is a reasonable treatment option.
And what about basketball players who have a sudden movement on the quadriceps?
Again, I think for basketball players, historically, we've been doing a lot of patellar tendon autograft. But this is also a population of patients who, have a high incidence of abnormal patellar morphology. They could have patella alta or issues like that. If we have Osgood-Schlatter, that's also quite common in our basketball population. So I think quadriceps tendon plays well in that population as well. So I don't, we've historically been harvesting from the extensor mechanism, and we've been able to rehab these patients quite well. And my opinion, and we haven't necessarily seen this out in the literature, but again, knowing that the hamstring is a secondary stabilizer against anterior translation, I don't like using the hamstring graft, particularly in elite athletes. And particularly in female athletes, because those athletes tend to be more quad dominant anyways. And we know that hamstring strength can be protective against re-rupture. So I prefer to harvest from the extensor mechanism.
And what is the patient population where you wouldn't prefer a quad graft? I mean, where you would definitely go for a semi-T or the other one, PTB.
So I think in my practice, the patients that I'm a little bit apprehensive to harvest a quadriceps autograft are patients who I'm a little bit concerned about their ability or interest in postoperative rehab. I think quadriceps getting the quadriceps muscle strength is often what we're gauging postoperative progression on. And if I've got a patient who I'm concerned they don't have the ability or the interest to rehab, they might not move through therapy. And those are patients who might not be necessarily trying to get back to elite level of activity. So when I've got a patient who's got a little bit of instability with daily activities of living, getting in and out of their cars. I live in Texas, and a lot of people have trucks and SUVs, and just getting in and out of those vehicles can be kind of an instability causing event. Patients like that, I think, are good candidates for hamstring tendon, particularly if they're younger, and a better candidate for autograft.
Thank you for that. And which side do you keep the bone when you're using a quads graft, on the female side or the tibial side, the bony part?
I generally will put it on the femur side.
Okay,
If
so
you're doing
yeah.
a double bundle graft, I would do it the other way. I generally reconstruct ACLs as a single bundle unless they have a very large footprint on their preoperative MRI, where I would consider doing a double bundle, in which case I would flip it. But generally, I'll put that patellar or distal side in the femur, whether I'm doing bone or soft tissue.
And what is the minimum graft diameter that you expect for all your patients? Is it 8 mm or more than that?
So I think the data is quite clear. If we use a graft smaller than 8 to 8.5, we have an increased risk of failure rate. Now, that being said, I do believe what Dr. Fu talks about with trying to match what your anatomic insertion site is. So if we've got a particularly small individual, so if you've got someone that might be 5 foot tall, and they've got a very small ACL, I think it's reasonable to aim closer to an 8 than a 10. I certainly don't harvest a 10 on everybody. So I think for me, if I want to get a 10, I'll get a parallel blade with 10 millimeters, and I'll reliably get a 10 millimeter graft. Versus if I want to get a smaller one, I'll use either a 9 or even an 8 millimeter graft. And the nice thing with a quadriceps tendon is if you use an 8 millimeter double blade, but you want to harvest a little, like an 8.5 or a 9, you can just get a little bit more thickness and reliably get a bigger graft too.
And Chris, suppose you have a multi-ligament situation or a double bundle situation. Do you think we can harvest the quads plus the hamstring from the same knee? Is it going to really impair the mechanics of the knee?
I have done that, and again, I don't think there's any study out there that's going to be able to tell us what we can do. I can tell you anecdotally, in my experience, it was a big rehab, but they are big rehabs with the surgery. I would prefer to do that over harvesting the quadriceps and the patellar tendon, because I feel like that's too much to be taking from the extensor mechanism. For a double bundle, you can get away with just the quadriceps tendon. You get a nice, approximately that little layer between the rectus femoris and the vastus medialis, or excuse me, the vastus intermedius. You get a nice double-limbed graft just by the anatomy of the quadriceps tendon, and you can get a large enough graft to be able to do a nice double bundle.
Thank you, Chris. Senthil is also online. Senthil is a staff orthopedic surgeon again from Dallas. Senthil, your questions to Chris.
Chris, very nice talk. Yeah, like quadriceps, like I saw in your talk, like only 10% of the surgeons use quadriceps, but a lot of us want to do the transition. When I was doing ACL, I was mainly doing a BTB guy with bone block on both sides. So if I start the transition, like if a BTB surgeon wants to transition to a quadriceps graft, what's his backup? Because once you try to take out from the quadriceps size, and if you're a little short, do you keep autograft as backup?
I do keep autograft as backup. What I would encourage for people who are transitioning, it's really hard to reliably replicate this in the lab, because oftentimes we'll get specimens that are just knees and there's no tension on the quadriceps. So it's really hard to replicate what you see intraoperatively. I think the easiest way to learn this graft is to just make a 3 or 4 centimeter incision and harvest it open. And you harvest it open a couple of times, and then you make that incision. You can use the endoscopic tools open so you can see what you're doing. But I think for me, anytime I do an ACL, I always have an allograft as backup, and I always talk to the patient on what they would want to do should the graft for some reason be insufficient. But I think this is something that, particularly the first maybe 2 or 3 grafts, you harvest with a bigger incision so you can see the anatomy a little bit better and replicate it. And I think the learning curve, I think, is actually pretty quick, that you'll start feeling comfortable to go endoscopic as well.
Okay. And you were talking about suspensory fixation for this. Do you use the same suspensory fixation that you use for a hamstring graft, or is there a special one that goes for because I've used the bone suspensory fixation for the BTBs, but I don't know if for the quad tendon is the same suspensory fixation, like the tightrope and stuff.
Yeah, so the suspensory buttons are all the same, and all the different companies have, Arthrex, Smith and Nephew, ConMed, they all have their suspensory buttons, and they're all the same. The difference with the quadriceps tendon is the graft preparation. So there's different proprietary devices that are designed for the quadriceps, but there's no data that shows. So, I think there's one that has a suture tape that they encourage you incorporate the suture tape into it, but there's no evidence that suggests that that's necessarily superior to just a lock crack house stitch. But I think for a lot of surgeons, I think one of the impediments to converting to the quadriceps is the harvest and graft prep time is a little bit more, particularly than the patellar tendon, but also even the hamstring tendon. So it takes a little bit longer to feel comfortable preparing the graft. And even for me, I still take longer by probably about 5 or 10 minutes than a patellar tendon autograft. So it does add a little bit of time to the case.
That's good. I don't have any other questions, Chris. Thank you. It was a good presentation.
Yeah, thank you, Chris, for the fantastic presentation. And actually, if we could have a demonstration of how you do the harvest, I mean, it would add much more value. And if possible, if we can record or get a presentation online where we can see how the graft is harvested. I'm sure there are a lot of presentations on, the Arthrex one, Striker, they all have, but since you have a presentation background here, and if we have a video presentation later on, it would be fantastic.
Wonderful. I'll put something together for you.
Yeah. Thank you, Chris. I think that's all the questions that we have for this session. Fantastic lecture at another time. And we really look forward for another one later on. Thank you so much.
My pleasure. Thank you for having me.